Hi, I'm Dr. Scott Whittle, and I really appreciate you joining me here in the discussion. What I'd like to talk about today is ways that we might improve mental health care and substance use disorder, especially from the point of view of the patient experience. I think all of us agree, treatment providers, administrators, patients, I think we all agree we have serious challenges, in fact, probably historic challenges in terms of access to care, meaning you in a lot of cases just can't get into care in a reasonable time frame. You can't get in there within a week or so. Most people are waiting weeks, if not months, to get into care. And when we do get into care, care is generally good, but I think the whole healthcare journey is unfortunately seriously uncoordinated with a real lack of collaboration. And I really don't mean to point fingers at anybody. This isn't about what people are doing wrong. I think it's really about how the system of healthcare delivery that we've built is kind of built to get the results we're seeing today, especially with complicated healthcare conditions like substance use disorder, mental health conditions, and even chronic medical conditions with individuals that might have more complicated needs. To really understand this, I think we have to go back a little bit and understand what system we built, and then I hope to do that fairly quickly, because the exciting part of this discussion is the second part. It's really where improvement is possible and what next steps might be to really change the healthcare delivery experience, especially with chronic and complicated conditions, many of which are in the mental health area and in the substance use disorder area. So let's get to that point as quickly as possible. Now, going back to what system have we built, I think most people would agree mostly our system is what we call a fee-for-service system. That means that no matter how complicated and how big our healthcare delivery system is, we pay for it one chunk at a time in kind of discrete or individual episodes of care that don't join together well as one healthcare journey. We just don't get to the place where healthcare is reasonably coordinated. Let me dive deeper into what I mean by that. Let's take an example. Say treatment of depression. Treatment for depression for most people is pretty straightforward, but for a lot of people, a sizable minority, it's more complicated than just simple healthcare delivery. So let me define what simple looks like. What simple looks like for a lot of people is they recognize they might have an issue with something like depression, and they go to their insurance company or they talk to their group of friends and find maybe a talk therapy provider, maybe a medication management provider. And when they enter that outpatient healthcare delivery part of the continuum of care, they then get connected to enough to meet relatively straightforward needs. Consistent talk therapy and medication management. That is, if you can get an appointment. Access is a serious problem we have right now. But if you get in, you have a pretty good shot at having relatively straightforward needs get met. But that isn't everybody's experience. Many people's experience goes beyond outpatient care and steps up into higher levels of care. And let me give you a picture of what I mean by the continuum of care. If you can imagine a line of care that on one end has highly acute care, like needing an ambulance to be called or having law enforcement involvement to help you get to maybe an emergency department or a receiving center. And these are places where in a moment of crisis, somebody can get a good evaluation that would help figure out what that person probably needs next in their healthcare journey. And then at the other extreme, you have outpatient care, which we talked about before. That's therapy, medication management, and straightforward community-based services like that. But in between the two extremes, there are a lot of levels of care. You have things like intensive outpatient, which is care that's provided 3, 4, maybe 5 times per week, sometimes more. That care is more hours than a usual therapy session, maybe 3, maybe 4 hours per day. Then you have partial hospitalization, and partial hospitalization usually happens about 5 days per week, sometimes more. And then you have, above partial hospitalization, you usually have something like residential care, which is every day like partial hospitalization, but you sleep there at night, so you have trained and licensed individuals that can provide care 24 hours, at a minimum at least 16 hours a day. So that's largely what a continuum looks like. There's additional pieces that fit in there to kind of fully complete that continuum of care, but those are some of the big pieces. And fee-for-service care is built to kind of pay for chunks of that. So say you go to the emergency department, they suggest you are hospitalized on an inpatient unit, then that care is provided, and it can be high quality care. You can have a great outcome from that care, but when you finish that care, that billing is submitted to whoever the payer might be. It might be the patient, it might be Medicare or Medicaid or commercial insurance, or to the patient themselves. So that care is kind of closed off. And no further payment is provided to help collaborate, coordinate, or is based on the outcome of care that goes beyond that one chunk of the healthcare experience, because that's not where care stops. That individual is going to, in all likelihood, be referred to a lower level of care to continue that healthcare journey, with the ultimate goal being that they end up back at that community-based level of care. They're living more kind of at the lowest level of care possible that still meets their needs in a successful way. And they don't have to have so much intrusion of care into their lives. So that's what we're looking for. But the next step might be, let's say it might be partial hospitalization. The collaboration and coordination piece is the inpatient unit where that person received that great care should be providing a fair amount of information, like a treatment plan, obviously with privacy, with releases being signed, and you as a patient being willing to share that information, say, yeah, please coordinate care. Then that treatment plan, specific information that would help guide treatment to have it be more successful, should be shared. But with the fee-for-service system, what actually happens is most of the time the individual never makes it to the next level of care. And I mean most of the time. The majority of the time that next step is missed. And whatever progress was made on the inpatient unit, you hope that that improvement is durable, but the ideal outcome was that healthcare journey take the proper steps with that treatment plan being completed, because if you don't get to that next step, it's just a fact that your treatment plan won't be completed in all likelihood. And so whatever the next several steps were are lost, and that creates what we call the revolving door. The revolving door of high intensity services like ambulances, emergency departments, receiving centers, hospitals, inpatient units are all being used to respond to a crisis, but the next steps don't get the follow-through they need. So in all likelihood, because these are usually chronic conditions, that individual is going to have another crisis. We don't, you hope not, but most chronic conditions don't just go away, and another crisis means that whole system of care gets activated again, that individual's life is disrupted again, and that revolving door starts. Now, my experience watching this from the point of view of a healthcare executive is that most people who end up needing that level of care end up going through those levels of care between 6 to 7 times before they get to the point of being stabilized, getting the care they need and feeling like they're back on their feet. Most people have that revolving door go 6 or 7 times. So I just want to reflect on that for a second. That experience is incredibly expensive, but more than that, it's incredibly disruptive to people's lives. That part of the healthcare journey comes with risk, where people might get hurt in the process. When you have a crisis, there are a number of risks that are poorly managed at that point, and it's incredibly expensive. So essentially, with lots of care in the mental health area and substance use disorder, we're paying for care 6 or 7 times on the highest cost parts of the healthcare system before an individual is having a successful healthcare journey and getting to the place where they want to be, which is a place of stability at the lowest level of care, less life disruption, more feelings of independence and autonomy, really what we're all looking for in healthcare delivery. So the revolving door phenomenon. I think that explains the healthcare system that I've experienced my entire career. And I think, if you find that description of healthcare to resonate, I would really appreciate you being willing to share comments below that might explain what your experience has been. A lot of people say, I spent years in school to learn about these areas, but individuals live their entire life with these issues. And so you bring a wealth of knowledge that I think I would benefit from hearing about. That takes us to the second area, that a fee-for-service is this uncoordinated, because it's not paid for, uncoordinated low collaboration strategy that works for people with simple needs, but for people with more complicated needs, it just honestly doesn't work very well. What would be the solution? And this for me is the more exciting part of the discussion. I've lived with the other challenges for my entire career and watched, people struggle to make the fee-for-service healthcare system work. But there are better choices, and we have regions of the country making progress towards building a different payment structure that largely falls under the umbrella of value-based contracting. And what value-based contracting does is it switches the paradigm. So instead of paying for chunks of service within a continuum, you shift the focus to treating for outcomes. So you're going to be paid for the services, but in the form of being paid for a positive outcome for the whole healthcare journey. And maybe a simple way to think about this would be, say, from a surgery point of view. It's a little bit easier to understand what that healthcare journey might be if we're talking about something like, say, a knee replacement. So if you go for a knee replacement, to have a good outcome, a number of steps have to happen. You have to have wound care so that you don't have a post-operative infection that destroys your good clinical outcome and dangerous and costly. You also have to have some rehab so you can get the leg to work appropriately again, so you get your mobility back and you're back on your feet. So that's a good surgical outcome. And I know it's more complicated than that, but for simplicity's sake, you have to follow these steps. And if you don't follow those steps, you're at risk of an infection, you're at risk of the leg not working right, and the functioning you were hoping for isn't going to be achieved. So instead of paying for the surgery, which is quite expensive, and then separately paying for the rehab, and then separately paying for the wound care, you bundle it all together. And you say, we're really paying surgeons to coordinate all of that care, make sure it happens, and get us better outcomes more of the time. And that's what you're being paid for. So if you fail to do that, and the individual has a bad outcome, has infections or has lower functioning, and you don't get the good surgical outcome you're looking for, then that healthcare team might not get paid. And that's being paid for outcomes. It seems just fair that that's what healthcare should be. We focus on how our care helps people so that people get the healthcare they need. Again, not villainizing people, but just saying that if collaborating, coordinating isn't part of the outcome we're looking for, and it's not paid for, it just doesn't happen. In practice, we've seen it just doesn't happen. Despite all the good intentions, all the good people in healthcare, nobody has time to provide care that isn't part of the goal, isn't part of the contract of providing healthcare. So we just have to switch that paradigm. So bringing that back to behavioral health, what that would look like in behavioral health is when that individual ends up needing to go to the emergency department, for example, going to an inpatient unit, and that treatment plan is started and next steps have to occur, just like that knee surgery, that payment should be dependent on everybody in that system working together to get that individual to the right outcome, which is back home with talk therapy, medication management, and the supports needed to catch things early, to intervene early and use relatively straightforward services like in-home services, respite care. There's all kinds of things that can be applied at a low acuity, low dollar amount level to help that individual get the good outcome and to keep that good outcome instead of going through, again, that revolving door. So what it would look like is providers agreeing that together, because no one provider works in all those levels of care, they have to then collaborate and they have to come together and they have to say, I work with this inpatient unit, we contract together, and we get this individual all the way to where they need to be, and together with that good outcome, we get paid. And it looks like being paid fee for service, but you're really being paid for that positive outcome. It seems pretty straightforward, right? And it honestly makes sense. Anybody in business knows that I can be fixing cars and I can buy all the wrong parts, apply them to a car, get a poor outcome, and nobody would expect to have to pay for that. But medicine hasn't been built that way. Medicine has been built that every little piece of the system gets paid whether we work together to get the outcome that people deserve or not. So time to modernize, time to make things better. Taking this whole idea a step further, and I think this is really the big story in mental health care and in substance use treatment, is clinically integrated networks. This is just basically an idea that various parts of the country have been working on, where providers group together and create what they call a clinically integrated network. Is they share information, they set goals on what successful treatment would look like, and then they contract with the big payers, with the private health insurance, through large employers, through Medicare, Medicaid, and they create the structure that allows for contracting for getting to the good treatment journey as quickly and efficiently as possible. All that occurs with data sharing, because you have to have an organization to share data. You can't just share data with anybody. You work together to set goals with all of the parties within healthcare, and what does a good outcome look like, so you can agree, and when you get to that good outcome, you get the payment. And if you show improvement over time, again, to that quality improvement idea, when you show improvement over time, that payment should increase, because there are healthcare savings, there's dollar savings associated with getting to the right outcome the first time, instead of that revolving door where we force people to re-engage with the system by just not staying engaged with them, not getting them to the treatment they need. So clinically integrated networks, there's some phenomenal examples within the country, both in medicine and pediatrics, and Colorado has a fantastic CIN. Arizona has a behavioral health CIN that's built to do exactly what we're talking about. Utah at this point in time doesn't have a clinically integrated network, but it's something that's been kicked around, and other geographies certainly do. I would encourage you to look up clinically integrated networks. The One Care Network is a strong clinically integrated network system within the country for providing mental health care. So a lot of good possibility in that area. That's one of the ways to actually make the progress we're looking to make in healthcare. Again, I'd love to hear your comments. If you've had experiences with one of these more integrated systems of care, if paying for outcomes makes sense to you, or if you have a different point of view, I'd love to hear about it, please, in the comments below. If you like the content, think that it's valuable, please help me with the algorithm. Give me a thumbs up and hit the subscribe button. I really want to put content out here to help inform people of what's happening within the healthcare system and help make you be a part of healthcare decision making. Thank you very much.